Welcome back and thanks for joining us. Today I'm going to discuss step 2 of the population health cycle. But first, a quick review. The population health cycle is composed of steps all beginning with the letter S. They are select, survey, segment, sell, solve, score, stop, start, same, start again, or cycle. In episode 1, we reviewed the select step of the population health cycle. We discussed some of the selection criteria one might use to determine who is in the program you are running. As part of this, we also discussed some exclusion criteria and a few key points to consider. In this episode, I'll introduce you to step 2, survey. This one is going to be thick, and my apologies in advance. Remember, as I said in the prior video, the devils are in the details. And while this video may appear loaded, it's scratching the surface of the details and work required. So what do we mean by survey? There are paper surveys, email surveys, texted surveys. I get so many spam political surveys in my text messages, they drive me crazy. But in this case, we're not just talking about mailing a survey or sending a survey to somebody's email account. Sure, that could be part of it. But here I'm using the term survey in the broadest sense of the word. From the Merriam-Webster dictionary, we have survey, to examine as to condition, situation, or value. Fascinating when you take those three words, condition, situation, and value, and apply them to this process and population health programs. What's the current condition of the population and the individuals within it? What's the situation the population and individuals exist in? And what's the value of what we propose to do or have done? As we move to value-based care, how do we maximize the typical value equation where value equals quality over cost? Now, value to whom is another issue entirely, and one I plan to cover after finishing this series. Based on the dictionary, survey is about gathering data from all of the relevant sources, including the condition data, such as claims data, medical chart data, pharmacy and behavioral health data, what sorts of healthcare services they use or conditions they have, clinical data, the value of various labs and other tests, biometric results, perhaps even genomic and other omics data. One might also gather HRA data, quality of life data, such as an SF-12 or 36, and various mental health screenings, such as for depression or anxiety. These mental health screenings have become more important as people have recognized the incidence and impact of depression on those with chronic diseases. One should also look to gather persona data such as readiness to change or patient activation measures. And for situation data, where they live, their access to services, transportation, and the social determinants of health data. And value data, what was the quality of the service, outcomes, and costs. The key is to gather as much relevant data as possible for several reasons. One is to be able to appropriately segment the individuals into various groupings that are usually established based on risk. But these data can also be used to identify what you need to solve for and how you might do it in the solve step. And third, if you don't collect certain data up front, you may have no way to compare data at the end that is needed to score your program. At the same time, gathering data just for gathering's data's sake can be problematic. It creates additional work. For example, the data you gather may have little or no impact on your segmentation model, or in later steps such as solve, you may have nothing you can do for the issue you identified, or in your score step, it may not impact that. At the same time, you may be gathering data to determine if you need to develop something to address an issue, or it might lead to a better understanding of the patient and population. Maybe you have a hunch about something that might prove beneficial to know. One of the key points to consider in this area is that of impact. I have seen problems created for program staff when data is gathered for which the program has no ability to solve it. For example, if you're gathering, say, housing issues and presenting them to your staff, and they have no way in your system to address the issue, this can create incredible frustration for employees. Another example might be genetic data. Here, you could be gathering data for an individual that says whether or not they're at risk for developing Parkinson's. While this might be interesting to know, at this time, given current treatment options, just being at risk for Parkinson's is not something that can be impacted. And furthermore, in this case, it might cause undue stress for the individual or be something they did not want to know about. There are a number of other points to consider when determining what you will gather via the survey step. 1. Do I have the right data to understand the individual well enough that I can appropriately segment them into groupings within the overall population to maximize my ability to know what to do it efficiently, and ultimately maximize their health while minimizing costs? 2. Do I have the right data to know what to do to sell them into the program and get them to enroll and participate? 3. Do I have the right data to identify gaps in care, barriers, and issues faced that the program needs to solve? And 4. Do I have the right data to score the program and measure outcomes? Answer those questions correctly, and you have a good start to the survey step of the population health cycle. Other points to consider is how often do I need to reassess the population or individuals? Might that be quarterly, every 6 months, or annually? And which measures do I need at which times? And now a big one, becoming much more important. Joe Kvedar coined the term the Internet of Healthy Things to describe this revolution. It's patient-generated health data. We now have all of these devices and apps monitoring our health or available to monitor our health connected via the internet. These data too need to be incorporated into the survey step and used on an ongoing basis through the program and during the reassessments. Using these data can allow one to better tailor the program to the individual, as well as create greater efficiencies by having earlier access to potential problems or issues being faced. Aggregating all of this data is the issue we face as we continue to try to create interoperability. Yes, we still may need to fax things, enter PDF documents into the records, and deal with unstructured data, but we are making progress. So there you have it in a rather large nutshell. Step 2, survey. Make it broad, make it deep, understand what you need, how and from where you'll get it from, and get yourself going. If you'd like to discuss your population health or care management program, reach out to us at info@accountablehealthllc.com. Please feel free to share this video and comment below. In our next episode, we'll discuss step 3 of the population health cycle, segment.